So in this video, we will describe the superficial fascia of the anterior abdominal wall. Okay. So remember, the superficial fascia of the anterior abdominal wall is double layered. The idea is, just look here. You can see, you can wrote like this. This is the pubic symphysis, pubic tubercle. Here comes a anterior superior iliac spine, and this is the inguinal ligament, and this is a median plane. We have umbilicus over here. Okay, so if we make an imaginary line connecting the anterior superior iliac spine, this is the anterior superior iliac spine. Up to this imaginary line, the anterior abdominal wall superficial fascia has got single layer, and below this imaginary line, this layer or this superficial fascia is double layered. Okay, so it has got two layers below the line joining the anterior superior iliac spine, and the superficial fatty layer and deep membranous layer. The superficial fatty layer is known as the fascia of Camper, and the deep membranous layer is known as the fascia of Scarpa. So we have Camper's fascia superficially and membranous Scarpa's fascia deeply. Now let us see the fatty layer. So the superficial fascia or the superficial fatty layer of the anterior abdominal wall is continuous with the fatty layer of the rest of the body. Okay, and two three points you should remember. In penis, what happens actually in case of males? So if I draw like this, so this is the anterior abdominal wall. We have the umbilicus coming like this. So here we have the penis. This is the penis and scrotum. Okay, so this is the superficial fatty layer. When it comes to penis, okay, so this particular fascia is called penile fascia. It forms the penile fascia over the penis. And remember, the penis fascia is devoid of fat. And again, the same fascia when it comes to the scrotum. So when it comes to the scrotum, it forms a muscle that is known as the dartos muscle. So smooth muscle, that is the dartos muscle. So remember, dartos muscle, which is a specialized muscle which is present in the scrotum. Okay, so that is the continuation of this Camper's fascia of Camper. Now what about the fatty layer, that the fascia of Scarpa? Okay, so what happens actually? So here you can see, so if we draw here we have the membranous layer on either side. In the midline, this membranous layer is attached to the linea alba. You know, the linea alba is a median white line. It is attached to the median linea alba, and here we have the inguinal ligament. What happens when we trace this membranous layer inferiorly? What happens? It passes behind the inguinal ligament. Here we have the inguinal ligament, behind the inguinal ligament, and enters the thigh. In the thigh, it is fused with the fascia lata. You know, fascia lata is a deep fascial thigh. Okay, so here we have the fascia lata, and in the thigh, this membranous layer is get fused with the fascia lata. Okay, then you know there is a Holden's line. Okay, so here if I draw like this, see, we have the pubic symphysis over here, pubic tubercle, inguinal ligament, anterior superior spine. Okay, this is the median plane and the umbilicus. So what happens actually? So if this is the pubic tubercle. Okay, if we make a line from the pubic 8 centimeter long line from the pubic tubercle, what happens actually? This particular membranous layer, it passes behind the inguinal ligament. Okay, so here we have which layer? We have the fascia lata. Okay, fascia lata in the thigh, and the fascia lata, it is fused here. Okay, so this line of fusion is known as the Holden's line. Remember, the line of fusion of the membranous layer, that is Scarpa's fascia of the anterior abdominal wall, with the deep fascia of the thigh, that is the fascia lata, that line of attachment is known as the Holden's line. This Holden's line has got some clinical importance. Okay, you know where is the attachment to the Holden's line. Okay, after that what happens actually? you know here we have the pubic symphysis, and behind the pubic symphysis we have the urinary bladder. This is a urinary bladder. So there is a condition called extravasation of urine. Extravasation of urine. That means if any injury to the urinary bladder, so the extravasated urine, the urine will come out. This extravasated urine fills the superficial perineal pouch. This extravasated urine will fills the superficial, go to the perineum. That way it goes to the perineum and fills the superficial perineal pouch. It may go to the anterior abdominal wall. It fills the anterior abdominal wall up to a line joining the anterior suprailiac spine. Okay, and this extravasated urine fills all this region, but it will not enter into the thigh because of this Holden sign. You know there is a Holden sign. So the Holden sign is an attachment, line of attachment of the membranous layer with this deep fascia of the thigh, that is a fascia lata. So there is a strong attachment. That is why the extravasated urine cannot enter into the thigh, but it fills the superficial perineal pouch and the lower part of the anterior abdominal wall. Now, what are the other modifications of this deep membranous layer or the campus fascia? You can see. So here, this is the blue area is the campus fascia. When it is running downwards, okay, it covers the shaft of the penis up to the glans penis. This is a glans penis. Glans. Okay, it covers the shaft of penis or clitoris in case of females. Okay, here this fascia, it is known as the Buck's fascia. Buck's fascia. Buck's fascia. Buck's fascia. Remember, Buck's fascia. Buck's fascia. So Buck's fascia is the fascia covering the shaft of penis. After that, what happens? After lining this one, it covers the scrotum and it goes to the perineum. So here it is known as the Colles fascia. Colles fascia. Okay, so we have the Buck's fascia and the Colles fascia in the perineum. And one more thing, remember this one. So it again modified in the midline. Okay, so in the midline it is modified to form the fundiform ligament of the penis and clitoris. And one more structure, that is known as suspensory ligament of penis. This is a suspensory ligament and this is the fundiform ligament. Fundiform ligament. So these fundiform ligament, suspensory ligaments, Colles fascia and the Buck's fascia, these are all the modified deep membranous layer. Modified deep membranous layer. Now let us see the cutaneous blood vessels on the anterior abdominal wall. Before that, okay, so I told you the anterior abdominal wall has got two layers, superficial fatty layer and deep membranous layer. Superficial fatty and deep membranous layer. Okay, so here between the superficial fatty layer, this is superficial fatty layer and deep membranous layer, in the lower part we have got three blood vessels are there. Three blood vessels. Okay, these three blood vessels as well as some lymph nodes are present in between these two. Remember, cutaneous blood vessels and some lymph nodes are present between the superficial fatty and deep membranous layer. Okay, let us see what are the blood vessels present over here. Okay, so based on the blood supply, so we can divide the anterior abdominal wall into three areas. There is a lateral area. This is the lateral area. Then there is a medial part and there is a lower half. Let us see. So the lateral half, so we have the posterior branches on the posterior intercostal arteries. We can see the branches on the posterior intercostal arteries. Okay, in the medial part we can see two blood vessels. There is superior epigastric artery and the inferior epigastric artery. Superior epigastric artery and inferior epigastric artery. In the lower part we have three blood vessels, that is the superficial external pudendal, superficial epigastric and superficial circumflex iliac. Okay, so it is somewhat like this. Okay, so in the medial half we have from an artery which is coming from above, that is superior epigastric artery. Below there is inferior epigastric artery. Superior epigastric artery is a branch of the internal thoracic artery, and inferior epigastric artery which is coming from the femoral artery. Okay, and in the lateral half we have the posterior in branches from the posterior intercostal artery, and the lower half we have three branches. One is going medially, that is known as the superficial external pudendal, okay, and the one which is going upwards, that is known as the superficial epigastric, and the one which is going laterally, that is known as the superficial circumflex iliac. So these are the main blood vessels which supplies the cutaneous blood vessels which supplies the anterior abdomen. Now what are the veins? Okay, so the veins, mainly we have so many veins over the anterior abdominal wall, and we have already seen that this umbilicus is a watershed line. Okay, above the umbilicus the veins drain drains upwards, and below it is the veins draining downwards. Okay, so above the umbilicus the veins, that is the thoracoepigastric, we have a thoracoepigastric vein. Thoracoepigastric vein drains into axillary vein, and finally axillary veins opens in, finally draining into the superior vena cava, you know that. Then this, below the umbilicus we have superficial epigastric vein. Drain into the great saphenous vein, and great saphenous vein into the femoral vein, and finally femoral vein draining into the inferior vena cava. Now the same in case of the lymph nodes. Okay, above the umbilicus the lymphatic drainage, lymph vessels drain into axillary lymph nodes, and below the umbilicus they are drained into the superficial inguinal lymph node. That means above and below the umbilicus the direction of the lymph and the venous channels in opposite direction. That means the umbilicus is a watershed line. That means around the umbilicus, if we see around the umbilicus, there is a communication between the tributaries of superior vena cava and inferior vena cava. That means above the umbilicus the channels going to axillary vein and finally drain to superior vena cava, below through the femoral vein going to inferior vena cava. That means the umbilicus is a region where there is the anastomosis between the blood vessels, the tributaries of superior vena cava and inferior vena cava. And during vena caval obstruction, so these channels will open up and provides collateral circulation. That means the superficial veins of the anterior abdominal wall form channels to bypass the site of venous obstruction. Okay, so if there is an obstruction in the superior vena cava, what happens actually, the veins of the anterior abdominal wall open up, and veins from the tributary superior vena cava passes through this bypasses through the venous channels, reaches inferior vena cava, and through the inferior vena cava they reaches the right atrium. Okay, so remember this point. And in severe vena caval obstructions, I already told you, that means the veins of the anterior abdominal wall open up. Okay, veins of anterior abdominal wall open up, and so here actually this is a case of vena caval obstruction. You can see these all the veins, you can see the veins become more clear. Okay, now let us see the nerves which supplies the anterior abdominal wall. So the anterior abdominal wall is supplied by the lower 6 thoracic nerves and first lumbar nerve. Total 8 nerves are there. Nerves which supplies, that is lower 6 thoracic nerves, that is the intercostal nerves, and the first lumbar nerve. Okay, first lumbar nerve is L1. L1 gives 2 branches, that is iliohypogastric and ilioinguinal. Okay, so here you can see the lower 6, that means T7, T8, T9, T10 and T11, and the T12 is called subcostal nerve, and L1 has got 2 branches, the 2 nerves, that is iliohypogastric and ilioinguinal. So these nerves supplies the anterior abdominal wall. Now outside we have the skin, below the skin we have the superficial fascia. Normally deep to superficial fascia we have the deep fascia, but in anterior abdominal wall deep fascia is absent. Remember this point, deep fascia is absent in anterior abdominal. Why it is absent in anterior abdominal wall? Because it gives it helps to distension of the organs or the viscera, Okay, and there are some areas where there is no D fascia. So in examinations they may ask, that is, in case of penis there is no D fascia, in scrotum there is no fascia, D fascia, in perineum there is no D fascia, and on face there is no D fascia. In face also there is no D fascia. So remember, these are the places where there is no D fascia. Now let us see the muscles of anterior abdominal wall. The muscles we have: external oblique abdominis muscle, internal oblique abdominis muscle, transversus abdominis, rectus abdominis. There is a small muscle called pyramidalis. These are the muscles of the anterior abdominal wall. Let us see the muscles one by one. Okay, the first one is the external oblique abdominis muscle. External oblique abdominis muscle is present just deep to the superficial fascia. Okay, so you can see this is the external oblique abdominis muscle, and see the direction of fibers. The fibers of the external oblique abdominis muscles runs downwards, forwards and medially. Downwards, forwards and medially. What are the origin? The muscle arises from the lower 8 ribs. You can see 1, 2, 3, 4, 5, 6, 7, 8. Lower 8 ribs. The muscle takes origin from the lower 8 ribs. Okay, and from here the muscle fibers runs downwards, forwards and medially. Downwards, forwards and medially. The lowermost fibers of this particular muscle get inserted onto the iliac crest. This is iliac crest, that is the anterior two-third of iliac crest. Outer surface of the iliac crest. Okay, and rest of the fibers going and inserted to the midline line, that is known as a linea alba. The linea alba. So here we have the linea alba extends from the, we have the pubic symphysis and the Seaford process. Okay, when the muscle go for insertion, okay, what happens actually, this muscle, when it reaches towards a midline, this is replaced by an aponeurosis. So this is the aponeurosis. This is the external oblique aponeurosis. Okay, and the lowermost margin of the external oblique aponeurosis extending from the anterior superior iliac spine to the pubic tubercle, and forms the inguinal ligament. So remember, inguinal ligament is the modified or the lower margin of the external oblique aponeurosis. So in examination they may ask, what is inguinal ligament? So inguinal ligament is derived from the external oblique, or it is formed from the external oblique aponeurosis. Deep to the external oblique muscle, we have the internal oblique muscle. Next muscle is internal oblique. The direction of the fibers is opposite to that of the external oblique. The fibers runs upwards, forwards and medially. What is the origin? Now let us see the origin of this muscle. So this muscle, the lowermost fibers of this particular muscle takes origin from the iliac crest. Okay, so we have the, again, now the muscle fibers takes origin from the inguinal ligament. Okay, that is the lateral two-third of inguinal ligament. Okay, then some of the fibers takes origin the intermediate part of the anterior two-third of iliac crest, and the posterior most fiber. So here is a fascia that is called thoracolumbar fascia. Okay, the muscle fibers takes origin from all these. The fibers runs upwards and medially, and the fibers, uppermost fibers, okay, so these fibers get inserted on the 7th, 8th and 9th causal cartilage. 7th, 8th and 9th. So here 7th, 8th and 9th causal cartilages. 7th, 8th and 9th causal cartilages. The remaining fibers forms aponeurosis. Here we have the aponeurosis and insert to the linea alba, extending from the Seaford process to the pubic symphysis. The next muscle, transversus abdominis. Transversus abdominis muscle lies deep to the internal oblique abdominis muscle. Direction of the fibers is that the fibers muscle runs transversely. That is why the name transversus abdominis muscle. So this transversus abdominis muscle origin from the lateral one-third of the inguinal ligament. then inner lip of anterior two-third of iliac crest, anterior two-third of iliac crest, and inner surface of the lower six ribs, inner surface of the lower six ribs, inner surface of lower six ribs. The muscle fibers runs transversely and most of the fibers runs horizontally, okay, and they are inserted onto the aponeurosis, through an aponeurosis inserted onto the linea alba. And next muscle is the rectus abdominis. Rectus abdominis is a vertically running muscle. The muscle fibers has got two heads are there. Here have a two head of origin. There is a medial head and lateral head. Medial head arises in front of the pubic symphysis, and lateral head of this particular muscle arises from the lateral part of the pubic crest. Okay, you can see that the muscle fibers runs upwards, okay, vertically upwards on either side of the linea alba, on either side of this particular linea alba, and they get inserted onto the 5th, 6th and 7th causal cartilage, 5th, 6th and 7th causal cartilage, 5th, 6th and 7th causal cartilage, muscle inserted. Okay, and remember, this rectus abdominis muscle does not inserted to linea alba. Remember this point. This muscle, rectus abdominis muscle, does not attach to the linea alba. Okay. One thing you can see, you have to notice that this muscle has got numerous tendinous intersections are there. So this structure is known as the vertical zigzag lines. You can see these are known as the tendinous intersections. Tendinous intersections. These tendinous intersections implies the segmental origin of the muscle. Segmental origin of the muscle. Okay, and what is the anatomical or the function of this particular muscle? This increases the strength of the muscle. This tendinous intersections increases the strength of the muscle, and this muscle, remember, it is responsible for our six pack. You know, six pack. Okay, so these tendinous intersections are responsible for the six pack. And the last one is there is a small muscle which is present on either side of the midline. That is one of the pyramidalis muscle. It's a small muscle, pyramidalis muscle is present on either side of the linea alba. Now we have already seen the linea alba. So linea alba, or the white line, it is a white midline, a line running on the midline of the anterior abdominal wall. You know how it is formed? It is formed by the aponeurosis of all the external oblique, internal oblique and transverse abdominis. All the aponeurosis get interlaces in the midline and forms the linea alba. So here you can see how the linea alba is formed. So we have external oblique, internal oblique, transverse abdominis, all the muscles meets at the linea alba. So remember this particular point. The linea alba is wider above the umbilicus. Supraumbilical part is wider and infraumbilical part is thinner. So this has got surgical importance. Remember this point. The supraumbilical part of linea alba is wider, whereas the infraumbilical part is thinner. Now let us see the structural modifications of these anterolateral muscles. Now we have already seen that inguinal ligament is modified part of the external oblique abdominis, right? So this inguinal ligament is the lower free margin of the thickened lower free margin of external oblique abdominis muscle extending from the anterior superior iliac spine. Here is anterior superior iliac spine to the pubic tubercle. So this part is the inguinal ligament. Okay, one more thing, there is a triangular gap. Okay, there is a triangular gap of the external oblique abdominis muscle lies immediately above the medial to the pubic tubercle. So here we have the pubic tubercle, just above the pubic tubercle. Okay, there is a small triangular gap of external oblique abdominis that is known as a superficial inguinal ring. Superficial inguinal. Now, you know, inguinal ligament is the modified lower margin of external oblique abdominis muscle extending from the anterior superior iliac spine to the pubic tubercle. It has got some modifications are there. First one is a lacunar ligament. So what happens, see, from the pubic tubercle, the medial most portion of this inguinal ligament has got a triangular modification, that is known as a lacunar ligament. Lacunar ligament, which forms the the medial border of the medial boundary of the femoral canal. You know the surgical importance of the lacunar ligament. Okay, so lacunar ligament, see, I tell you. So see the pubic tubercle. So here we have the lacunar ligament. This is the lacunar ligament, and this is the femoral canal. The femoral canal through which the femoral hernia occurs, through the femoral canal. Okay, so the femoral canal, that is femoral canal, medial boundary of the femoral canal is formed by the lacunar ligament. Okay, so during the surgical correction of the femoral hernia, so in case if we need to widen this femoral canal, okay, we need to resect this lacunar ligament. Okay, so by cutting the lacunar ligament, femoral canal can be widened by cutting this lacunar ligament. So during that procedure, the surgeon should take care of any abnormal obturator artery. Sometimes there is an artery present just behind this particular lacunar ligament, that is known as the abnormal obturator artery. Abnormal obturator artery. Okay, it may present, remember, it may present. Okay, sometimes there is an artery present just behind the lacunar ligament, that is called abnormal obturator artery. Okay, the surgeon has to, during this surgical correction of the femoral hernia or during the widening of this femoral canal, okay, the surgeon has to look after the abnormal obturator artery. Okay, another one is the reflected part of the inguinal ligament. This is the reflected part of inguinal ligament. We will discuss this reflected part later. And last one is the pectineal ligament. Pectineal ligament. So these are the three modifications of inguinal ligament. What are they? We have a lacunar ligament, then the reflected part of inguinal ligament, and the pectineal ligament of Cooper. Now let us see the structural modifications of internal oblique abdominis. First one is a conjoint tendon. What is conjoint tendon? Okay, so here you can see this is the external oblique abdominis muscle, this is the internal oblique, and this is the external oblique. What happens when it goes medially? So the upper neurons of the external oblique and internal oblique fuses to form a single layer over here. Okay, that is, so here is the external oblique abdominis muscle, here is the internal oblique abdominis muscle, this is upper neurosis. So when it goes for insertion, so what happens actually, these two muscles, external oblique and internal oblique, fuses to a single layer. So that is known as the conjoint tendon. Conjoint tendon. So conjoint tendon is the combination of upper neurons of internal oblique and transverse abdominis. Another one is the cremaster muscle. This is the internal oblique abdominis muscle, you can see. So the detached fibers of the internal oblique muscle which covers the spermatic cord. Okay, so these loops of muscles are known as a cremaster muscle. So cremaster muscle is the modified fibers of internal oblique. Now the structural derivatives of transverse abdominis. Okay, so first one is interfoveolar ligament. What is interfoveolar? So you can see the transverse abdominis muscle. Okay, so from the lower margin of the transverse abdominis, some of the fibers runs downwards and inserted to the superior ramus of the pubis. Superior ramus of the pubis. So these extended fibers are known as the lacunar ligament. Okay, fibers of transverse abdominis to superior ramus of pubis, and this is known as the interfoveolar ligament. You can see interfoveolar ligament.